Welcome to Pharmacology Part 2. I can feel your excitement building. So with this course, the main thing to remember is, of course, it's a tough course. Pharmacology in general is fairly difficult and it has a lot of different concepts to understand, and we move quickly. Main thing, definitely ask for help. So if you're not sure of the concepts that we've covered and we're moving on to the next one, please just reach out and ask for help. Chat with your peers. You have a whole group of students who are in the same boat as you. And I highly recommend starting study groups. They can be a lot of fun if you have the right people, and they can really help you push your knowledge in the topic. Likewise, please don't wait until you can't handle it anymore. I know a lot of us, including myself, procrastinate when stress starts to pile up. And it's actually really dangerous to do that because then all of a sudden, instead of just bobbing with your head slightly underwater, you're now drowning. And once you're drowning, it's really hard to get you back to where you need to get. So please, if you just feel yourself slipping in this course a little bit, just reach out, quick email, that's all it takes, and we can set up a meeting. And then, of course, if you have academic accommodations, just make sure you know the ins and outs and what is in place to support your learning so that I can then put those in place and support your learning as well. So the plans are to review the course setup, which I've already done through Blackboard, through that little video that I posted. The textbook that I talk about in the course outline and course syllabus, I highly recommend it. It's the Robert Bill textbook. The digital version is my favorite because you can highlight, make cue cards, flag pages, etc., all on the computer, your tablet. We will review a little bit in regard to pharmacology, and then we'll start tackling analgesics, tranquilizers, and sedatives, and then heading into anesthetics. And then, of course, all of these videos are available on the YouTube channel with the playlist link in your PowerPoint. So looking at our review of pharmacology from the last semester that we had together, what is the RVT's role within pharmacology? It is identification of normal and abnormal drug reactions, monitoring patient status while during drug therapy. So monitoring patient status while you've started a medication protocol, seeing how they're changing over time. Identifying patient response to the drug therapy, so are they responding positively or are they responding negatively? And implementing a reversal plan for patient drug reactions. And then, of course, always important to remember that all drugs are poisons. No drug is a silver bullet. All doses are guesses, and complacency kills. So we talked a lot about this with the last course, with the intro to pharmacology. All drugs are poisons, so we're trying to find the right dose that won't cause harm and will cause a positive effect. No drug is a silver bullet. So every single animal is different. They're going to react differently to a drug. We like to think that we have some miracle drugs out there, but in reality, there's not one drug that will cure every animal of the same illness. All doses are educated guesses, and complacency kills. So when we start getting used to doing the same drug protocols over and over again, we get in this habit where we become complacent, and that's where we can miss tiny little signs and signals that perhaps we should have looked at our drug protocol and adjusted it for that specific patient. Reviewing a little bit of terminology. So of course we have to keep in mind things like the generic name versus the trade name or proprietary name. The generic equivalent, a VPCR, which is the veterinary patient-client relationship, over-the-counter versus legend drugs, and controlled substances. So just familiarize yourself, take some time to go back if need be. If you can identify a few drugs by their generic name versus their trade name, such as meloxicam is the generic name, and then the trade name, of course, is Medicam. Generic equivalent, so that would be apomeloxicam, so that sort of generic base brand that's replicating that formula. And then the importance of the VPCR, so why veterinarians have to have a VPCR in order to prescribe and dispense drugs, over the counter versus prescription or legend drugs. And then of course we'll talk a fair bit about controlled substances. So we're going to get started with nervous system drugs. That's our topic overall for today and for the next lecture. We will work through analgesics, tranquilizers, and sedatives, and we will touch a little bit on anesthetics, and then head in later on, into CNS stimulating drugs. So looking at more terminology, we have these terms, which would be ideal to get to know. So nociceptor is a pain receptor. Opioids is a specific class of drugs that we will talk about. Neurolept analgesia is a combination of different drugs to produce a certain desired anesthetic or sedative effect. We will talk about agonists versus antagonists, and then drugs that are partial agonist antagonists. And all of these terms as well can be found in your textbook. So if you want to have them just on hand so that you can refer back to them, then you can certainly find them in the glossary of your textbook, and they're also at the beginning of this chapter. Okay, let's start it off with analgesic drugs. So in order to understand analgesic drugs and how they work, we have to understand how pain is transmitted through the body. And this in itself is a massive area of study, which is really exciting because, as we all know, long ago, people used to assume that dogs and cats and animals don't feel pain the way humans do. And even if I look back in my career, about 15 years ago, I had a veterinarian tell me that the puppies don't feel pain when you cut off their tails. And you can imagine now what we know about pain and what we know about pain prevention, that is just ridiculous. I didn't believe him back then anyways, and thankfully I didn't take part in those awful procedures. But still, it's not that long ago that we used to just dismiss animal pain. And now we're finding that pain has so many implications for the animals, so many long-term implications. So we have 4 phases of nociception, and essentially what we're talking about is pain perception. We have step 1, transduction. If tolerable threshold is exceeded, it turns into sensory electric stimulus. Transmission occurs when the electric stimulus is sent up the peripheral nerves to the spinal cord and then to the central nervous system. Modulation is the sympathetic reflexes stimulated to dampen the pain response, and endogenous opioid endorphins. So it involves endogenous opioid endorphins. And then pain is being aware or conscious of this process of nociception. So we'll go through it and look at our little pain pathway. So number 1, we have a pain stimulus. So we've got transduction of pain of a physical stimulus into excitation or depolarization of pain receptors, so a nociceptor. That is called transduction. So something bad happens to that area, and the depolarization of the pain receptor starts this pain pathway. Works its way up. While it's working its way up, that's called transmission, so that's step 2, and it's the conduction of pain impulses from that peripheral nerve bundle toward the spinal cord. So we've got our pain. Let's say somebody stepped on your dog's foot. That went through that transduction process where it starts to get translated into a pain response. Step 2 is transmission. It's working its way from the peripheral nerves up to the spinal cord. Step 3 is modulation, and this is where the transmission of sensory depolarization wave from the spinal cord to the brain perceives the pain. So it's that continuous wave of transmission from the spinal cord toward the brain. And then, of course, the last phase is perception, and it's the brain's ability to actually perceive the level of pain. So you can see here, hopefully this helps, how pain works in the body. There's a stimulus, it's translated into a pain response, works its way up toward the spinal cord. From the spinal cord goes to the brain, and in the brain is where it's really perceived, and that's where the body identifies what level of pain is this. So that being said, One thing that's nice about our field, we are always advancing, especially in the area of pain medication and pain prevention and prevention of pain windup. So we have levels of prevention at each of these areas of the pain pathway. So if we look at various methods of prevention, during the transduction phase, local anesthetic can be applied to the area prior to inducing pain, and that will block the pain pathway and the pain receptor will avoid depolarizing. So we can add a local anesthetic to the area before we actually enter in with a scalpel blade. And what that's doing is it's stopping those pain receptors from actually depolarizing and starting that whole process. During transmission, or in the transmission phase, we can use local anesthetic to block a peripheral nerve bundle to prevent transmission of pain pathway up to the spinal cord. So that means that potentially there's pain hitting that peripheral bundle of nerves, but now we're blocking those nerves from making their way up to the spinal cord. And this might be something that you don't see that often, but more of a deeper nerve block, so into the brachioplexus of an animal, or if they're going ahead with some kind of orthopedic surgery, then you might see very directly the specific local anesthetic being applied to nerve bundles. During modulation, many analgesics will act by increasing the degree of inhibition or dampening the pain signals that reach the conscious brain. So if we're looking at inhibition during modulation, that sort of middle phase, then we can add analgesics and we can prevent that pain from getting all the way up to the brain to be perceived. So one thing that we have to talk about, of course, is pain windup, and we'll talk about this a little bit in regard to prevention when we talk about ketamine. But pain windup is the idea that all of these phases, so we've got transduction, transmission, and modulation, essentially that those phases are still happening while an animal is under anesthetic, and we've removed their ability to have conscious thought because they're under anesthetic. If we don't give a pain medication and we only give an anesthetic agent, all we're doing is preventing that animal from reacting. So we're preventing it from reacting, and we're also preventing it from building up in the brain and then perceiving the pain. So what can happen with windup, let's say we anesthetized an animal, it's going in for surgery, we check its reflexes, yeah, it's asleep, and we make the assumption that it's not feeling pain. So in that instance, if we've not given any analgesic drugs, any pain drugs, then that animal is still going through those phases of the pain pathway. It's just that the brain is not able to perceive the pain yet. So then, when the animal wakes up, they can actually be in way more pain, and they can be perceiving way more pain than they would have ever perceived had they been given an analgesia or an analgesic drug. So it's sort of like it builds up and builds up and builds up during this whole transduction, transmission, modulation phase. And then as soon as the patient wakes up, all of a sudden it's like they're hit with a garbage truck and it's just filled with pain. It's like they're hit by a truck because all of a sudden their brain wakes up and they're perceiving everything that's been building up in their body. So that's pain windup, when it's sort of an irrational or over-exaggerated perception of pain upon recovery from anesthetic, and the most often the cause is a lack of appropriate analgesic drugs during the anesthetic surgery, whatever it may be. So looking at analgesic drugs, they prevent this windup, which is really important, and the goal is to create balanced anesthesia and pain management, so working them together to maintain anesthesia and then to prevent pain windup and overall pain. So we're going to work our way through. We're going to start by looking at various analgesics, and we'll start with opioids. Opioids, of course, have been in the news a lot lately because we have an opioid crisis in North America. These are extremely addictive drugs. So looking at the actual word opiate, it is a substance that's directly derived from poppy seeds. And then we have the pharmacological version, the chemically synthetic opioids. So the opioids mimic the effects of opiates. So they mimic the chemical effects of these poppy derivatives. They're also known as narcotics, and they get that name because they cause narcosis or a stuporous state. So a state where a patient is generally out of it, in a stupor, reduced sensations. The use is to reduce pain. The use also is in combination with anesthesia to reduce the amount of overall general anesthetic that's needed. So we often talk about like a pre-anesthetic cocktail that we give to an animal before we give them a general anesthetic drug. An opioid is quite often in that pre-anesthetic cocktail. Opioids as well were originally used to treat diarrhea. You can read about this, I believe it's in your textbook. So they also have this effect where they really shut down the gastrointestinal system, which also sadly, of course, can create serious constipation. So who knew they were originally used to treat diarrhea? They work, we'll talk about a little bit in a minute how they work, but they work by binding to certain receptors within the central nervous system. So it's mu, kappa, and delta receptors. And with this, opioids bond with specific receptors in that gut to decrease the gastric motility overall. So sometimes that's a good thing, sometimes that's a bad thing. Definitely if an animal's on opioids for a long period of time, we have to be very cautious because they can get really, really constipated, which is not ideal. And as mentioned 17,000 times, they're extremely addictive. So looking at how they worked, as mentioned in the last slide, they are receptor-based. So what we're looking at here is the plasma membrane on a cell wall. So we've got the hydrophilic and hydrophobic ends, and then we have these little receptors on the plasma membrane. So the receptors will only bind with certain air quote shaped substances. So we have a mu, a kappa, and a delta receptor. And they have presynaptic and postsynaptic effects. So we'll go through this a little bit more. When it comes to overall analgesic effects, the opioids bind to the specific cell receptors and prevent, so they stop, depolarization of that receptor by creating an effect on the cell. If it's presynaptic, it means that it prevents the release of a neurotransmitter. And if it's postsynaptic, it means that it actually creates an inhibitory effect. So if we think about all of this, allowing a cell to either be stimulated or to take away that stimulation, that's what opioids are doing. And we'll talk more about this. Don't you worry. So a little bit of a review. Going back to anatomy, we've got the plasma membrane, which is involved in chemical signaling, so chemical signaling between cells. And it has binding sites on the plasma membrane that fit a specific shape. So the example, bringing this back from Anatomy 101, looking at those little receptors that fit a specific shape, those specific binding sites, those are opioid receptors. So that's what we're talking about in this case. Opioids themselves typically work as an agonist or as an antagonist to these receptors. And then we have certain drugs that are partial agonist antagonists. So they are mixed. Many opioids are mixed antagonist agonists. I guess I should avoid, it's not many, but some of them are mixed. And they combine with multiple types of opioid receptors. So looking at a bit more terminology, because these are words that we just have to have a general understanding of in order to understand and explain the opioid talk and how the drug works, the whole physiology of the drug. So an agonist is a drug with a good affinity for the receptor and the ability to produce intrinsic effect. So what that means, drug with a good affinity for the receptor, that means that it's a drug whose molecules fit really well with that receptor. So it's like perfect puzzle piece, they're going to connect. So it has the ability to dock at that cell and then has the ability to produce an intrinsic effect. So that means that not only does it connect, but it actually has an ability to have an effect on the cell. An antagonist is a drug with a good affinity so that puzzle piece fits, but little or no intrinsic effect. So in these cases where it's an antagonist, I like to think of it as the drug itself is simply taking up space on that cell. It's simply taking up receptor space so that other drugs can't connect to have an effect. So it takes up space, but it's not going to have any effect on the cell. It's just there, just taking up a receptor. Then we have partial agonist-antagonist when two drugs bind with a receptor and cause intrinsic effect. The drug that causes the lesser effect is the partial agonist-antagonist, and we'll come back to that. And then we have competitive antagonist when the effects of one drug stops the effects of another drug when connected to the same receptors. And how we'll talk about this, of course, is to discuss which drugs belong into which category and how they're working on the body. So this is the same slide as before. We've got agonist and antagonists, and then we have partial agonists and antagonists, mixed agonists, antagonists, etc. So here's a really super high-tech visual for you. So we've got an opioid receptor. Look, we gave that animal some hydromorphone, which is a really potent opioid. It's one that we use all the time as part of the pain management protocol for surgery, painful animals. So if we look at that, I'm just going to go back because it's so high tech. So if we look at the shape of the opioid receptors, I don't know what that is. It's half of a hexagon, whatever you want to call that shape. So we see that we can have a really flat side. So we know that whatever drug we're administering has to have that missing puzzle piece to fit this shape. So if we bring in the hydromorphone, oh, there it is, look at it. It fits perfectly, and it's like the missing puzzle piece. So hydromorphone fits perfectly. It's wonderful. Now, not only will hydromorphone fit perfectly, but it also is an agonist. So it's going to have an effect. It will have high level of effect for that patient on those cells. So it has 4 to 6 hours of high level pain relief. It can cause respiratory depression. Hydromorphone, I'll come back to, but it is a full agonist. And then we have another drug. So let's say that animal has a broken bone. That bone, actually that's kind of a bad example. Let's just say they're super painful, it's some kind of gut pain, and the doctor thinks that they've got peritonitis. So we need to not only give them pain medications, we gave them some hydro and it clicked really well with the opioid receptor, but we also want to give that animal some antibiotics so they get some amoxicillin. What we find in this case, so that amoxicillin is floating around the body, it's getting circulated, it's getting absorbed, etc., but it will not connect to an opioid receptor. So it could have effects all over the body, and it's working on different areas of the body, but it does not fit the shape to allow it to connect to an opioid receptor. Again, I know this is such a high-tech drawing. So it has no effect. The drug doesn't match the receptor shape. It doesn't even stand a chance. Then we have this guy, butorphenol. So butorphenol is also, it's a recorded drug, so it's a controlled drug, and it has some pain relief mechanisms. It's also used as a sedative. So butorphenol, if we look at it, it's going to fit the opioid receptor. It's perfect. It's an opioid. It's fitting the receptor. That's great. It's got the shape that we want. However, butorphenol only gives us 30 to 60 minutes of pain relief. That's not that great. That's not a lot of pain relief. But now that we've introduced butorphenol, because it fits with an opioid receptor, it's actually taken up some of those opioid receptors on the cells, and we need a really high level opioid to work for a longer period of time. So unfortunately, this is where we get into partial agonist antagonist. So what's happening here, we've given hydromorphone, which is a wonderful opioid, 4 to 6 hours high level pain relief. We've given hydro, and we also gave butorphenol, because somebody told us to and we didn't know any better. That's not a good reason to do things like that. Because butorphanol is an opioid and it's going to fit the opioid receptor shape, it's going to sit there. It's going to sit on these receptors. But butorphanol is a really crappy pain relief. So it has very, very short-acting pain relief mechanisms. So now it's just taking up space. So it does have some intrinsic effect on the cell. That's great. It has some effect. But because it has such a crappier or shorter pain relief window, it's really unfortunate, and it becomes this partial agonist antagonist. So it actually interrupts the full agonist effects by stealing receptors away from it. So this is lesson number 1. In general, we never give butorphanol and hydromorphone together. And the reason for that is essentially they're canceling each other out. So the butorphanol could actually reduce the efficacy of the hydromorphone because it's taking up too many opioid spaces, too many opioid receptors. And butorphanol lasts a lot less or a lot shorter of a duration than hydromorphone. So lesson number 1, future RVTs, we don't give butorphanol and hydromorphone in the same pain management protocol. We would have to wait until the hydromorphone has washed out of their system, so after 6 hours, then we could start butorphanol if that was the case. We'll talk about buprenorphine as well. It's the same with buprenorphine. We don't give buprenorphine and hydromorphone. They will be partial agonist antagonists acting against the full agonist. We could, however, give butorphanol and buprenorphine. So examples of our agonists versus antagonists. So the mu agonists, so remember these are the ones that click really well with the opioid receptor, and they're going to have intrinsic effect. So not only are they definitely going to hit that opioid receptor, but they're going to have a big effect on the cells where those receptors are. Examples are sort of those pure opioids. We've got morphine, hydromorphone, oxymorphone, and fentanyl. The effect on the body is great analgesia and generally a level of sedation. The negative effects, because there are always negative effects could be vomiting, could be respiratory depression, which is our biggest concern with opioid use, dysphoria, anorexia, urinary retention, so they're holding in their urine, initial diarrhea, and then long-term constipation. So initially that GI tract gets sped up with opioids, and then long-term opioids will cause constipation. Looking at a subclass of mu antagonists, we have naloxone. So naloxone is a drug that definitely connects with the opioid receptor, but it has 0 intrinsic effects on the cell. So if we go back, butorphanol does have some effects. It definitely fits and it definitely has intrinsic effects on the cell. They're just not as good as hydro. Whereas naloxone, if you think of it taking up exactly the same shape, connecting with that receptor, but then it's just sitting there and having 0 effect on the cell. So the purpose of naloxone, by taking up places on the cell through like taking up receptor space and having no effect, having no intrinsic effect, it actually reverses the symptoms associated with full mu agonists. So that's kind of cool. So we use naloxone as a reversal agent for many of the pure mu agonists. Did you know that mu agonists also depress the respiratory system? I literally just mentioned this, so I hope that you know this. But looking at the biggest concern with these pure mu agonists is that they depress the respiratory system. So, not good in some doses, great in other doses. This goes back to, doses are guesses, and we do our best to guess with, education behind us. And also, all drugs are poisons. So looking at this, we use Vicodin, which is hydrocodone syrup. And if you think about oxycodone, which is another opioid that people take, so Vicodin, hydrocodone, is an opioid syrup that we actually use in the veterinary hospital for severe coughs. So an animal that has serious residual coughing, let's say after they've healed from a kennel cough episode, then we might give them Vicodin to help suppress that cough and maybe allow them to sleep, allow them to actually get some rest. So it's interesting because we fear the fact that these pure mu agonist opioids really can depress the respiratory tract, the respiratory system. We fear that because if we overdose them, they're going to die. But we also utilize that characteristic as well for a cough suppressant. So of course, if we suppress the cough, if we suppress the respiratory tract too much, we're looking at an animal that is no longer alive. So that's a big, big thing to remember when we're using opioids. So we're going to look at some of the specific opioids and talk about them and how they work, how they're administered, what we might use them for. So morphine is kind of the OG, it's the original. The efficacy of morphine alone for surgical pain is not ideal. So now you tend to see morphine mixed with other drugs as part of an anesthetic protocol rather than used as the sole sole analgesic drug itself. So it is an opioid. The trade names generally are just morphine in various terms. The mode of action, it's a mu agonist, and it has some kappa agonist activity, and we'll come back to kappa. Positive effects, analgesia, so that's what we use it for. It's excellent for visceral, so for gut pain and for superficial pain receptors. It can be used as an epidural drug, and quite often it's used in combination with a local anesthetic as an epidural drug. And low doses can cause euphoria, so that's a good feeling. That's a feeling of happiness, essentially. Side effects, if we give this intramuscularly or subcutaneous, the animals, typically the dogs, will salivate and vomit. And remember, that goes back to opioids, whether they reach the emetic center in the brain first, which happens when we give it sub-Q and IM, or if they hit the CRTZ first, which happens if we give it intravenously. Higher doses can cause really pronounced dysphoria. So dysphoria is past euphoria, and it's like euphoria is happy and sunshines and unicorns and whatever, and then dysphoria is when like the unicorns are trying to kill them. So they start to get that dysphoric, unhappy feeling, and they look really out of it and uncomfortable. They can get meiosis, so commonly in dogs, rabbits, and rats, meiosis will occur, or mydriasis in cats and horses. And it can cause so if given IV, it can cause a slight histamine release. So there's potential that it could cause a histamine release. And there is debate about the full effect it has on the body, whether or not it produces a clinical vasodilation and reduced arterial blood pressure. It could be more profound when given with drugs that decrease cardiac output. So there's potential. If we get a histamine release because of this drug, then we're going to get severe or more severe vasodilation, which isn't ideal. If we have a mast cell tumor, so if it's an animal with a mast cell tumor and we're going in to do surgery to remove the mast cell tumor and we're using morphine, it is beneficial, more beneficial to give it intramuscularly or sub-Q just to potentially avoid that intravenous potential for histamine release. Because if we go back to last semester talking, remember that mast cells are those little cancer cells that are covered in histamine granules. So if we're going to cause an increase in histamine release, then we can cause a pretty major systemic allergic reaction. Not ideal. Did you know? You do know this. Apomorphine is a derivative of morphine, and it's used to stimulate the dopamine receptors to produce emesis. So you guys learned all about this if you were with me last semester. We talked about it ad nauseum. Get it? Ad nauseum, because it causes nausea. So it's used to stimulate the dopamine receptors to produce emesis, and again, it doesn't work very well in cats, but boy, oh boy, it sure works in dogs. And most often, I'm going to scratch that sub-Q. Somewhere it's listed as giving sub-Q. We don't really give it sub-Q at all because in that case, it could actually go to the brain first and suppress the emetic response. So let's just scratch out the that sub-Q and maintain that it goes IV or transmucosal to produce an emetic effect. So just going back to morphine, just to talk a tiny little bit about morphine. So when animals are in pain and they're given morphine, and when they're given opioids in general, so vomiting in general is a common side effect of giving dogs morphine, hydromorphone, etc. Common opioid side effect. However, an odd fact is that when animals are in true pain, so animals have a serious pain response, and let's say they're not just getting the drug because they're going to have a surgery, and maybe it's part of the pre-anesthetic cocktail. If they're in pain and we give these drugs, the vomiting almost never occurs, and there's less dysphoria. And there's arguments about why that happens, whether the pain itself is taking up receptors, it's taking up space, changing the physiological reaction to the drug. But it's kind of neat. We always expect a dog to throw up if we give them hydro or morphine if it's a pre-anesthetic agent, but if they're actually painful, it's wild that they don't vomit. It's crazy. It's kind of neat. Okay, hydromorphone. So this is the really good pure agonist. It's a pure mu agonist. And it is a very widely used and very fantastic opioid for pain. It lasts 4 to 6 hours. It can easily be given sub-Q, intramuscularly, and intravenously. We tend to see less emesis if it goes intravenously. Trade names are Dilaudid, and that's super common in human medicine is Dilaudid. The one thing that we have to remember, we might use Dilaudid, but quite often we're using like the Sandoz brand, which is kind of a borderline generic brand. But I really, really, really want you guys to remember that with hydromorphone, it's most often sold as a 2 mg per mil and a 10 mg per mil concentration. Why is that so important? Because if we draw up a dose for a cat and we accidentally use the 10 mg per mil instead of the 2 mg per mil solution, suddenly we're giving 5 times the dose, and you can pretty much guarantee that that cat's going to go into respiratory distress. So this cannot ever be overlooked, ever, ever, ever. And this, when you're in school, most often they just have one specific concentration, but when you're in clinic, a lot of times we have 2 mg per mil and 10 mg per mil. So as noted, the mode of action, it's a mu agonist. The positive effects, it's an analgesic. It has wonderful analgesic properties at a lower dose than morphine, so it's more effective than morphine at lower doses. It has less emesis stimulation than with morphine, less histamine release when given IV compared to morphine, and longer duration than morphine. So most clinics are using hydromorphone, and most clinics are not using morphine for day-to-day regular routine surgeries. Side effects, it can cause more significant hyperthermia in cats. So hyperthermia in cats is something that can be associated with opioid use, and hydro is one that can cause a little bit more hyperthermia in cats. Intramuscularly or sub-Q, generally the animals will salivate and vomit. Higher doses can cause dysphoria, and then of course same meiosis or mydriasis. Now, one thing to remember that's kind of nice when you start working in regular practice, if you choose to, then what you'll find is sometimes clients think it's better to not tell you the truth than to tell you the truth. And it happens all the time. So clients might have realized that they accidentally forgot to take away the food from their dog last night and their dog's supposed to have an anesthetic. We know that if a dog has a full belly of food and they're going under for a general anesthetic, if they regurgitate, that could be really serious. Like that could go into their lungs. We could have a massive problem. It's a big deal. Not good. So sometimes clients forget to tell us, oopsies, I left Fluffy's food out all night. Ha ha ha, she's not actually fasted. So something that is kind of nice is if we use an opioid, especially with hydromorphone, if we give it IM or sub-Q as part of our pre-anesthetic cocktail, If it makes them barf, it's wonderful because that always can tell us right away, was the animal fasted, yes or no? And if the animal has a massive amount of vomit, then it's very likely that the doctor will say, we're not doing the surgery today, fast the animal, come back another day. So it's kind of cool. Helps empty out their gut for us. Okay, next up, fentanyl. I'm certain that anybody watching this video has seen fentanyl in the news excessively over the last 5 years, as we currently have an epidemic with fentanyl drug use. It's definitely known as a street drug. It's an opioid. The trade names that you'll often see are Analgesic. It's a mu agonist, and the positive effects, it has great analgesic properties at a lower dose than morphine. Essentially, that's it. It doesn't last as long necessarily, but we'll talk about the different methods of using it and how we can sort of titrate that dose. So it has short duration, so that could be a good thing and that could be a bad thing. It depends on why you're using it. Higher doses definitely will cause dysphoria. Meiosis or mydriasis definitely occurs, and challenges with administration due to short duration. So we have to look at how we use fentanyl. It tends not to be a IM injection every 4 to 6 hours or an IV injection every 3 hours. We have to look at a continuous rate of infusion for fentanyl to maintain an effect. So with that, quite often we're using a transdermal patch, as seen in this image here, and it's based on the overall surface area of the animal. So it's not a perfect science. It's not quite the same as basing it on the animal's weight. It has to be on a clean shaved surface. And the key here, when we're using a fentanyl patch, you really should get the right strength of fentanyl patch and not cut the patches. Some clinics I do see cut the patches. There is a lot of danger in cutting the patch to, quote, ensure that you're getting the right micrograms per patch. So the reason we recommend or advise against cutting the patch is, well, if we cut the patch, number one, it's just like splitting a pill that doesn't have, I don't know why I can't remember what they're called. Score, that doesn't have a score in the middle. There we go. So if you cut a pill and it's not a scored pill, then you don't know when you have two half pills if both of those halves have the equal amount of medication. So in this case, if it's a 25 microgram per hour, let's say, but let's say this total patch has, let's say 150 micrograms embedded into this patch. If you cut it in half, you're expecting 75 mics on one side, 75 on the other. The reality is that it could have 100 mics on one side and 50 on the other. So it's just not a perfect science if we cut them in half. Likewise, cutting the patch will actually alter the rate at which the medication is released, which is really, really scary. So you can see here on this one, it says 25 micrograms per hour. That's how often or how much is getting released and how often. If we cut that, we alter that, and that could be really, really serious. And the alcohol-based gel that's inside that sort of gets the medication to the patient, that alcohol-based gel will evaporate, and it will completely screw up the rate of administration. So instead, if you don't have the right size patch, then the patch, half of the patch can actually be covered with tape, or the packaging can be left on half of the patch. It still doesn't take that variable. About half the patch might have more medication than the other, but it's definitely not going to change the rate of absorption. So those are just things to think about, things that you might see in your field. It does take 12 to 24 hours for the patch to be fully effective. So that being said, if the animal is painful when they leave your clinic and they're leaving with a fentanyl patch on that you've just applied, that animal, we need to make sure that we place the animal on pain medication before we send them home with a fentanyl patch. So sometimes animals will come to us with a fentanyl patch, or they'll come to us with pain medication on board, and then we sort of transition to that fentanyl patch, knowing that it takes 12 to 24 hours to be fully effective. They can be left on for 24 to 72 hours in the dog and up to 4 days in the cat. So you can think about some benefits there, right? Kind of ideal. The owner doesn't have to pill them. If it's a patient who's in hospital, We have this continuous rate of infusion, transdermal infusion through the patch. We don't have to worry too much about it, except for maintaining the patch. The exact location is identified in the packaging by the manufacturer, and the goal of that is to ensure absorption at the rate specified by the manufacturer. So tricks with the fentanyl patch, they're really good. Like they can be really handy, they make it accessible, they can be a part of this really well-balanced anesthetic or analgesia protocol for a patient. There are always some concerns, so we have to remember that we are sending an animal home with potentially a high dose of a highly addictive, highly effective opioid stuck to their back. So what if the patch falls off? What if the cat or dog still seems painful? Do we have to think about, is the patch working? Are we safe to give more opioids? What if a kid takes the patch off? What if the dog eats the patch? That's super dangerous, and you can imagine that certainly happens. And the list goes on and on. So there's a lot of concerns with the fentanyl patch. So we really don't just send a client home with a fentanyl patch and treat it like a bandage. Oops, we're going to go back to that. We have to have a long conversation with the client about the fentanyl patch, about the risks involved, the fact that it could be fatal, etc., etc. So we don't ever take this lightly. All right, that's my rant on fentanyl. Okay, moving on to another drug, butorphenol. This guy's a little bit different. So I used butorphenol in the example previously. So it is a mixed agonist and antagonist. So it stimulates the kappa receptor. So it's an agonist for the kappa receptor, but it also binds with the mu receptor, but produces little effect. So it binds and produces an effect on the kappa receptors, and it also binds but does not produce an effect with the mu receptors. And keeping in mind that these receptors are over a ton of different cells in the body, and they are part of that pain pathway. So they can, in that case, take up space on the mu receptor and essentially block other mu stimulators, so mu agonists, from working. So that's the example that if we give hydromorphone and butorphenol at the same time, it's going to have some effect because it's butorphenol, but it's short-lived effect, and it's actually going to block the effects of hydromorphone. It's also considered a partial mu agonist and a partial mu antagonist. So it has a dual effect on the receptors. Buprenorphine, which is similar to butorphenol, similar opioid, it's a partial mu agonist, and it binds with the mu receptor and creates an effect, but it's much, much milder in effect than other mu agonists. So again, talked about not giving butorphenol with hydro because it kind of cancels out the effect of hydro by taking up space on those receptors, on the mu receptors. Buprenorphine is the same idea. We try to avoid it when used with hydromorphine or morphone. We try to avoid mixing those two together because it's going to create a milder effect than hydromorphone on those mu receptors. So here's our handy dandy chart. Butorphenol, it's an opioid. Trade names, Torbigesic, and it's 10 mg per mil concentration. Mode of action, partial agonist antagonist. It can be a weak mu agonist to mu antagonist. So that means that it can have a weak effect on the mu receptors plus strong kappa agonist. So it's going to have a strong effect on kappa receptors, and then it could be either a weak effect or completely no effect on the mu receptors. Positive effect, it can be used to reverse some of the respiratory side effects of pure mu agonists. So potentially, if we have an animal that's had hydromorphone at a high dose and they're having trouble breathing, there is potential that if we only have butorphenol available, we could give it, and it will take up space on some of those receptors and help lessen the effects of hydro. It can be used at 0.1 to 0.3 mg per kg for excellent sedation, and it has less respiratory depressant effects compared to hydro. So we often are using butorphenol not for its primary pain management characteristics, but we're mostly using it for its primary sedative characteristics. and it's also an excellent cough suppressor. Side effects, it's not as potent as morphine. It has a ceiling effect, so that means that it will only create such a level of an effect, and it can't continue to go higher no matter how much more we give. Has a very short duration of analgesic properties, so I want you to keep in mind this is like RVST, or RVST, who the heck is RVST? RVT cornerstone lesson number 2. Butorphenol should never be used on its own as a primary analgesic drug for a severely painful animal because it only has a 30 to 60 minute effect. It can be used in combination, and it can have a synergistic effect when used in combination. That's okay. We'll talk about that as we go down the line. But it should never just be given butorphanol and expect that to be long-lasting pain management. Buprenorphine, carrying on, is also a controlled substance. I should mention all of these are controlled substances because they're opioids. So buprenorphine is more recently being used. The trade name is Analgesic, and that's at a concentration of 0.3 mg per ml. And it's also been compounded into various concentrations. So we get a lot of compounding pharmacies that can create various concentrations of buprenorphine products. Mode of action, it's a partial mu agonist and a kappa antagonist. Positive effects, it lasts longer than other opioids, so it has a good duration of effect at 6 to 8 hours. It's the least likely to produce negative effects associated with opioids, so that's kind of nice. It has less of those negative effects. Has rapid absorption across mucous membranes, so we quite often can give this as an oral dose going home with the client, and they tend not to have too much of a problem with it. It's great for feral cats because you can spray it into their mouths. There's an option for a 3-day slow-release buprenorphine injection as well, and it's easy to give at home. Side effects, it's not as potent as morphine, and again, it has that ceiling effect where even if you keep giving more and more and more, it's only going to work so well for pain control in that animal. Also super important, as you know, I just mentioned that there's a 3-day sustained release injectable buprenorphine option. Always make sure you know if you're using that version or the regular version, because we would not want to give a sustained release when we only want 6 to 8 hours of pain medication. And then carrying on, this isn't our last one that we'll talk about, but Tramadol is it's a funny one. So it's kind of like an emerging centrally acting analgesic. So in general, it's considered a controlled drug generally. However, I think that may be debatable where you are. I actually have to check up on that because I think originally it was debated as to whether or not it was, so I will have to come back to that. But either way, it's sort of an emerging type drug, and it's a centrally acting analgesic, plus it has some opioid receptor activity. So that's why I'm keeping it in this analgesic talk and with the opioids. So trade names, in humans it's Tramadol and it's Tramadol mixed with acetaminophen. In general, for animals, we're looking at compounded tablets in 10, 25, 50 milligram, 100 milligram tablets or capsules. The mode of action, it has lots of different modes of action for pain management. So it does have some mu agonist activity. It also prevents the reuptake of serotonin and norepinephrine. It also blocks receptors that normally respond to acetylcholine. It also stimulates alpha-2 receptors to produce sedation and analgesia. So it has all of these sort of, I want to say random, but they're not really random, but there's really varied set of mode of actions on the body. And with that, it creates a whole bunch of different effects, but pain management is one of them. So positive effects, it has some analgesic effect. It has better analgesic metabolism in the cat than in the dog. And some internalists even advise against giving Tramadol in the dog. However, in clinic, I find that most vets use Tramadol for dogs as opposed to cats because buprenorphine is a really great option for cats. So just some conflicting information, and I'm certain that by the time you graduate, there'll be more studies on Tramadol, and this will be updated. Side effects, in general, full extent of analgesic effect and the uses are not entirely well known. The dog, we know it's not overly well metabolized. We have to have caution when giving this. In general, it's not to be given with many of the behavior modification drugs. So any of those drugs that are classified as serotonin reuptake inhibitors, so SSRIs, it can cause this life-threatening condition called serotonin syndrome. So that's a little tidbit that you would want to know, definitely want to know about Tramadol. We avoid it entirely if an animal is on a select serotonin reuptake inhibitor, which is a behavior modifying drug. Moving on, we have Myperidine, which is a less common opioid now. It's known as Demerol. It was pretty common probably in the 90s and early 2000s. It has 1/5 of the analgesic properties, that should say, of morphine, so it's quite low on the list. It's a weaker agonist. It's a serious cardiac depressant. It's quite short-acting, oral injectable forms. And unfortunately, there's a ton of abuse with this drug. So this drug is definitely a street drug, and it's one that's highly addictive. So there's actually a number of individuals in the veterinary profession who have found themselves in the clasps of addiction, and this is one of those drugs that falls within that category. So you can see why it was phased out, and we really don't use it much, although who knows, like these drugs definitely come back, and all of a sudden in referral medicine or orthopedic surgery, you'll see these starting to be reintroduced in like a continuous rate of infusion or something along the lines. So I say that right now in regular practice, we don't often use Demerol. So then with our drugs, we always want to know what's normal, and we need to know what's abnormal reactions to drugs. And we talked about opioids. If we give too much of an opioid, we're going to get dysphoria. So that's that very uncomfortable feeling of being out of control. It's like their brain is completely out of their body. And also, really seriously, we have respiratory depression. So if we give the patient too much of an opioid, there's potential that we could kill them because they're going to go into severe respiratory depression. So if we give too much of an opioid, so hydromorphone or morphine, thankfully we can give them an opioid antagonist, which is going to fit with that receptor. It's going to fit with that mu receptor, and it's going to have zero intrinsic effect on the cell. So it works by competing for spaces both on the mu and kappa receptors. So it's going to fit like the puzzle piece on the mu and kappa receptors throughout the body, but it's going to have no effect. So instead of the hydromorphone, which is connecting like a puzzle piece to that receptor, and let's say it's causing the muscle cell receptor to like cause the muscle cell to relax or whatever it may be. It's got a whole bunch of different properties to it. But let's say it's having a direct effect on that cell. That's hydromorphone. Naloxone does the opposite, and it simply has no effect. So in that way, it reverses the sedation, the analgesic, and the respiratory effects of the opioids when we give it. Caution with use. It's really best in the case of an overdose. We have to be very cautious in using this drug because we can't forget that it's reversing the analgesic effects of the opioid. So remember why we gave the opioid in the first place. It's because the animal is painful, or there's potential for it to be painful. If we give them enough naloxone, it's going to completely erase their pain management, which is really awful for the animal. Most often what we do in clinic is we draw up their dose, and it's either diluted or given straight, and we slowly titrate it to effect. So that means that we just push it through a syringe slowly to effect, to ensure the dysphoric effects are reduced, but the analgesic effects are maintained. So really, we typically are giving it just so that we start seeing them act a bit more normally and seeing them act a bit more comfortably. So an example, agonist, morphine. So we give morphine. It binds to the mu receptors and has intrinsic activity. So it's binding to those mu receptors, and it has a really great effect on the cell. The veterinarian's concerned that the animal is suffering from the effects of a high dose, so it has really good analgesic properties, but in high doses, the respiratory depression is set in. The vet orders you to give naloxone. Why? The answer is naloxone is a mu antagonist. So you can see here we've got a pure mu agonist, hydromorphones clicking into the receptors, having a great effect on the cell. Uh-oh, it's too much of an effect on the cell. Let's give naloxone. It's going to click into the receptor but have no effect. So now those receptors are taken up by this drug that causes no effect. So the result is the dog's mu receptors are now taken up by the naloxone, which is an antagonist instead of the opioid, which is the agonist. The dog shows less respiratory depressive effects. It shows less dysphoria. However, caution, if the dog is painful, we could be reversing the analgesic effects. So again, we don't use this when we don't need to, but it's there in case of emergency, most definitely. And then, of course, as always, opioids are controlled drugs, and this is your Georgian College Veterinary Hospital controlled drug log. Very important for you guys to be familiar with. Moving on, we have some analgesic drugs that are not opioids. And actually, I think we're just going to talk about this one. So, gabapentin is this phenomenal drug. It's not an opioid, so it's certainly not a controlled drug. And not that much is known about it, but we just know that it works really well. So it's technically classified as an anticonvulsant drug, although its use as an anticonvulsant is sort of becoming much less popular than its use as an analgesic drug and as a sedation-based drug. Most commonly for pain, we're using it for neuropathic pain. So pain that's stimulated or started by the nerve itself. So if we've got nerves that are irritated from osteoarthritis, rather than having an external stimuli that's causing the pain, we have a nerve-based pain. It's really good for that kind of nerve pain. It can be used as an adjunct to other pain management therapies. So we might be giving gabapentin and Metacam. We might be giving gabapentin and hydromorphone, who knows. It's excellent for senior pets because generally it's quite safe on the organs. It's wonderful for animals who cannot be given non-steroidal anti-inflammatories, such as animals with gastric ulcers or animals with reduced renal function. And it seems to, the way it works, it seems to reduce the release of glutamate, which is an excitatory transmitter. And I don't know if you remember glutamate from when we talked about some of the antiparasitic drugs that sort of would either, well, they would inhibit the glutamate receptors in these parasites, and then that would cause the parasites to go into a stupor. Same idea. So it reduces the release of glutamate, which in essence is going to cause a sedation-based effect. The oral dose, we're only giving this generally as an oral dose, and it can be compounded to suit the needs of the patient. So that means that it can be a liquid or a pill. And typically, something just to tell clients when we give gabapentin, when they're first getting gabapentin, the animal gets really sedated. Like it's pretty profound sedation. And then they actually seem to build up a tolerance to it. So normally by week 2, with gabapentin, they seem not to be as sedated as they were on the first day. Really great drug for fractious cats. Most often we're giving it as a liquid. We use it all the time on the spay-neuter trips that I do with the group that I work with. So before we even, we'll have a look at the feral cats, but if it's a true feral cat, then they're sitting in a cat trap. They've obviously been trapped, and we're going to release them after their spay or neuter. So we'll often squirt 100 milligrams of gabapentin into their mouth when they're happily hissing at us. And it gets in there, and it just takes the edge off. It's really, really nice for these guys. So we just squirt away as they're screaming and hissing at us, and they growl and say, yum, yum, yum. It's really excellent for old dog or old cat arthritis pain. So it's just something to think about, especially we see this starting to get used a lot with cats who are old and declawed, because we're now seeing that they have neuropathic pain in their paws. And then unfortunately, because gabapentin is such a wonderful drug that I think is great and I love it and I want every animal to have a whisper of gabapentin, unfortunately it's becoming a street drug. So that For some reason, I stopped writing drug, but it should say street drug. So just something, again, currently it's not controlled, but I know various provincial vet organizations have discussed whether or not it should be within the Controlled Drug Act, just because it can have certain addictive properties for people. All right, so that was our talk about analgesic drugs. So the majority of the drugs that we talked about were opioids. It's a good idea to get to know how each of those opioids work. So are they mu or kappa or mixed, mu and kappa, agonist or antagonist? Are they competing for space with another opioid, etc.? It's also very good to know the benefits of each of those individual drugs and then also the drawbacks or the side effects. All right, moving down the line, we're going to talk about tranquilizers and sedatives, which are widely used in veterinary medicine. And if you are my age, you have probably seen Old School, which is probably one of the best scenes in life, where he gets a dart in the neck. And that's all I ever think about when I hear the word tranquilizer, because I swear we never use it in small animal medicine. We use it in large animal medicine. But I always think of the tranquilizer gun at the zoo that was needed just in case like if they had to anesthetize a gigantic animal like an elephant, then quite often they would be using a tranquilizer gun, or a tiger. When I say that out loud, it sounds awful, but it was realistic. If it's an animal that's untouchable, unapproachable, a top carnivore, then they have to use a tranquilizer gun to administer medication. Anyways, that's my long-winded segue into tranquilizers and sedatives. So looking at the difference between tranquilizers and sedatives, tranquilizers, it's a drug-induced calm. The patient is reluctant to move but is aware of their surroundings. Whereas a sedative, it's a drug-induced depression of the central nervous system and drowsiness. It's aroused by a noxious stimuli, and it activates nociceptors, so nerves that transmit pain, chemical and thermal and mechanical. So we're looking at the activation of these receptors. Sedation and tranquilization does not equal analgesia, and it does not equal anti-anxiety. And that is a massive cornerstone lesson as well for future RVTs. Just because you've sedated something, depending on the drug that you've used, if it's a straightforward sedative, you have not provided analgesic properties, and you have not taken away their anxiety. Okay, it's really important to keep that in mind. It doesn't, in some drugs they do take away those properties, but that is not a broad spectrum statement. Just to say that you've, sedated somebody does not equal anti-anxiety or anti-pain. Okay, acepromazine is our first tranquilizer that we'll look at, and we have talked about acepromazine previously when we discussed it in regard to its antiemetic properties for dogs. So it's a phenothiazine tranquilizer. It has 0 analgesic properties. So that's super important to know. It will not decrease the level of analgesia or decrease the level of pain in your patient. It's often used to calm animals who are being hospitalized, sometimes for transport. Potential to decrease inhibition of seizures. So what that means is if the animal has a seizure condition and they are likely, there's potential that they could go into a seizure, then this has the potential to decrease the inhibition, which essentially is like taking that gate off and allowing the seizures to come through. So we don't want to use this in patients that potentially have seizure conditions. The data out on that is still in the middle, but in general, it's safer to say don't use in animals who are predisposed to seizures. It definitely can cause hypotension, and then also important, it's metabolized by the liver and excreted by the kidneys, so we have to be cautious in the patients that we're using it. We would not use this in an animal who has kidney dysfunction or hepatic dysfunction. And we can give acepromazine IM, sub-Q, IV, and orally as well. So acepromazine potential side effects, an alpha-1 receptor blocker. What that does is it ends up resulting in a blood pressure drop. So we want to definitely avoid with animals who are in shock or have potential to be in shock if they have blood loss or dehydration. We have to also watch out for hypothermia. And what else could we use this drug for? Well, we talked about it previously. We talked about it in using it as an antiemetic agent. So it does have that potential just to stave off emesis, and quite often, if anything, it's used in transport. Side effects, potential side effects of acepromazine, it's one of these weird ones that, yes, it's a tranquilizer. The goal is to make the animal calm and relaxed, but unfortunately, some animals, remember, drugs are not a silver bullet. Every animal is going to react differently. Some animals, it actually results in aggression and hyperactivity. So you never know how an animal might react. In other animals, it's beautiful relaxation and the nictitating membrane prolapse is occurring. So they start to look super, super stoned. Other animals, they get angry, which we don't want. Carrying on with acepromazine potential side effects, caution with use in stallions, so intact male horses. It can cause temporary or permanent penile prolapse, which would pretty much ruin your veterinary facility if you ruined a breeding stallion because you chose to use acepromazine. So that definitely has its risks. It's a little bit scary. Just be cautious. Always know your patient. So looking at acepromazine, it's a sedative tranquilizer, so a bit of both. It's a phenothiazine tranquilizer in its true class. Trade name's Atrovent, which is 10 mg per mil. Mode of action, it's an antagonist, so it's a blocker for many receptors, which with that we start to get some of the negative side effects associated with it. So it does have those alpha-1 receptor blockers, it's a dopamine receptor blocker, etc. Positive effects, it can cause profound sedation in small doses, and it can be used to prevent nausea and vomiting. Side effects, hypotension and associated concerns, so such as hypothermia. The seizure threshold decreases, or that seizure inhibition is decreased. It can add on to other effects of other sedatives or barbiturates. It has potential for unpredictable aggression or hyperactivity, potential for penile prolapse in stallions. So the key with this one, super, super, super important, acepromazine is for young, healthy dogs. Leave it at that. Young, healthy dogs, if they're sick, we're not going to give them acepromazine. If they're old, we're not going to give them acepromazine. Young, healthy dogs. Moving on to our next class, we have benzodiazepine tranquilizers. So these ones, if we're looking at how to recognize them, they tend to end in PAM or APAM suffix, and they are very calming drugs, and they have muscle relaxant activity. They enhance the activity of GABA receptors, which combine with GABA to inhibit neurotransmission. So let's have a quick look at this video, because it helps us understand about GABA and how GABA plays in the body.
I have to stop and tell you guys about
No ad. Well, okay, you have to watch it, I guess.
Lecturio, Lecturio.
Welcome to 2 Minute
Okay,
Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss benzodiazepines. Benzodiazepines are a class of drugs named for their chemical structure that are commonly used to treat anxiety disorders and sleep-related disorders. They include well-known drugs like Valium, Xanax, and Klonopin. There are dozens of drugs in the benzodiazepine class, but the mechanism by which they all exert their effects is thought to be similar. The sedating and anxiety-reducing effects of benzodiazepines are believed to be attributable to the drug's actions at receptors for the neurotransmitter gamma-aminobutyric acid, or GABA. In particular, benzodiazepines act at a subtype of GABA receptors called the GABA-A receptor. GABA-A receptors that also bind benzodiazepines are sometimes called benzodiazepine receptors. When benzodiazepines bind or attach to the GABA receptor, they bind at a location separate from where GABA itself binds, and exert an influence over GABA binding. This type of action is called an allosteric effect, and in the case of benzodiazepines, it results in increased action at the GABA receptor. There is not complete consensus on exactly how benzodiazepine binding affects activity at the GABA receptor, but there is evidence to suggest that it increases the likelihood that GABA binding will activate the receptor and/or increases the effect that GABA has when it binds to the receptor. That effect is to open an ion channel and allow the passage of negatively charged chloride ions into the neuron. This influx of negatively charged ions pushes the membrane potential further from zero, or hyperpolarizes it, and makes it less likely the neuron will fire an action potential. This type of neural inhibition is the basis for the effects of benzodiazepines, for by inhibiting the activity of neurons that make up networks involved with anxiety and arousal, the drugs are able to produce calming effects.
So essentially what it's doing is having an effect on the cell. When they combine, it's allowing chloride ions in, and essentially it's preventing depolarization. So it ends up having that sedating, calming effect. So benzodiazepines in general have zero analgesic effect, but they're often used in combination with analgesic drugs. And just as a side note, going back to that video, I'll post it as well through YouTube and through Blackboard, just in case the sound didn't work when you're watching this video. Benzodiazepines also create an inhibition of seizures. They are the primary line of defense in seizure activity. So if we look at the most common benzodiazepine that we use, it's diazepam, which is Valium, and that's the number one that we use in the case of a seizure. They also cause a lot of muscle relaxation. There's no obvious effects on cardiac or respiratory processes, and there is potential reversal with flumazenil, but that drug in itself can cause seizures. So in veterinary medicine, we tend not to use it. Additional uses for benzodiazepines definitely can be used as an appetite stimulant in cats, often when given intravenously. Just be cautious, it does sting intravenously when it's given on its own. The cats feel it, so sometimes they go to bite you at the IV site and then they quickly eat their food. Caution with long-term use, it definitely can cause liver failure. Side notes, this drug is light sensitive, so we always have to ensure that our benzodiazepine and benzodiazepine mixes are covered with a dark packaging or kept in a dark storage unit. And we have to have caution with plastic storage because the drug itself will break down when it's stored in plastic. So we don't store pre-drawn doses of Valium in plastic. It is metabolized by the liver, excreted by the kidneys. So again, we just have to be cautious with which patient we're giving this drug to. So looking at this class, we have benzodiazepines overall, which is a tranquilizer. I spelled that wrong. It should say tranquilizer, not tranquilizer. So diazepam, midazolam, lorazepam, clonazepam are all common ones that you might see. Diazepam, also known as Valium, is the trade name. We give it deep intramuscularly, intravenously, rectally, and intranasally, and that's the number one that you're going to see in clinic. Lorazepam is also known as Ativan in human medicine, and that's used more as a behavioral modification drug for anxious animals. Midazolam, also known as Versed as the trade name, we give it intravenously or deep intramuscularly, and that's sort of the second most common that you'll see in clinical medicine. And then clonazepam or Klonopin is used more for seizure prevention. Mode of action, it's working on those GABA receptors. Positive effects, we've got muscle relaxation, seizure inhibition. It's safe for cardiac and respiratory patients. Potentially reversible, but I wouldn't rely on that because that definitely could cause seizures. And then it can be used as an appetite stimulant. Side effects can only be combined with ketamine, so it does not mix well with other drugs. It can be combined with ketamine, and we use that to create this beautiful general anesthetic agent. And we need to flush the line in between other drugs because it doesn't mix well with water. It's semi-oil based product, but it doesn't mix well with water, and it could cause, it could change the composition of the product. So when we're giving diazepam, we always want to flush the line with sterile water, give the diazepam, and then flush the line again. And these guys, these benzodiazepines, are controlled substances. Next up, we have alpha-2 agonists, which are sedatives, and they have some analgesic property as well. The ones that we'll be talking about are dexdomitor, rompin, and dormicidin. So dexdomitor is dexmedetomidine, rompin is xylazine, and dormicidin is ditomidine. Older forms you will probably still see around Domitor. They did change the formulation of Domitor and combined it to make dexdomitor, which seems to be more effective at smaller doses. Alpha-2 agonists, we've learned about them previously because we talked about their potential emetic effect on cats. They are the best emetic agent for cats, most definitely. So in general, we're talking about xylazine, dexmedetomidine, and detomidine, and we use these on cats, dogs, and horses, and other large mammals. So detomidine and xylazine, we're mostly talking about large animal, if you can kind of get my odd little circling there, and detomidine as well, most often large animal. And they attach to alpha-2 receptors. They decrease norepinephrine release. So norepinephrine, remember, is hyping us up, and they decrease the release of norepinephrine within the CNS and the PNS. So that equates to a sedated effect if we're not allowing those excitatory neurotransmitters to be released. Normal action to maintain alertness, inhibition of norepinephrine release causes sedation. These drugs are wonderful as sedatives because they cause profound sedation. So this is an interesting drug. If you give it, especially most often we mix it as a pre-anesthetic agent. We'll mix it with an opioid. And when mixed with an opioid, especially butorphenol, it's like serious profound sedation. But even on its own, it can have regular profound sedation. It has more predictable sedation generally. There's a caveat to that I'll come back to. And it has a degree of muscle relaxant available to it as well. It has a decreased perception of pain. However, the sedation lasts longer than the analgesic properties. So we use dexmedetomidine a lot in clinics, so dexdomitor. And what we have to keep in mind is if the animal's quite painful, we can't simply sedate them with dexdomitor. Yes, it will have some analgesic properties as well as sedation. However, the sedation will last way longer than any of the analgesic properties. So what's going to end up happening is at some point you're going to get breakthrough pain, and that animal will either wake up screaming from their dexdomitor sleep because they're so painful, or they'll whip around and bite you because they actually can be woken up. They're not under general anesthetic. They're only sedated. So if they're quite painful, we have to remember that they really have the potential to bite when they're only sedated with dexdomitor or alpha-2 agonists in general. So just keeping that in mind. If it's a really stressed or a fractious animal, it's really best to mix with an opioid. So remembering that these alpha-2 agonists, they work by preventing the release of norepinephrine. If an animal is already so stressed out, they have a ton of norepinephrine that's floating around their body. So they've already released a ton of norepinephrine. They are totally high stress. So if we try to just give them an alpha-2 agonist, it's not going to be able to bring the norepinephrine levels down. It's only going to prevent the release of more norepinephrine. So what ends up happening, if an animal's super stressed in clinic and we only give them an alpha-2 agonist like dexdomitor, then the drug might not be able to combat that circulating norepinephrine, and instead the animal is going to remain hypervigilant and angry however they are at the clinic. And then as soon as that norepinephrine naturally decreases in their body at home when they're relaxed, then the alpha-2 agonist is going to start to really kick in, and the owner can actually have a seriously sedated animal at home. So not ideal in fractious or angry animals on its own. However, it's wonderful when it's mixed with an opioid. And a really good opioid is butorphenol. Dexmedetomidine and butorphenol together is fantastic for sedative properties. It does have a ceiling effect, so even if you keep giving more, you might not get a sedated patient, like a patient that's more and more sedated. It just might last longer, which is not ideal. Definitely causes vomiting in cats. We actually use it as an emetic agent in cats. And then just looking at xylazine and detomidine, it's really good for equine gut pain and colic. And xylazine, just a little bit of caution in barrel-chested dogs and cows, with the potential to increase the amount of gas that's present. So we have to talk about the downsides. We talked about It's not necessarily best used on its own in fractious or highly stressed animals. It is also riskier for older animals. So upon initial injection of these alpha-2 agonists, we get vasoconstriction, more so in xylazine and ditomidine than with dexmedetomidine. We get profound bradycardia, like profound bradycardia. So we had a dog the other day who, before anesthetic, its heart rate was like 120 and it was excited, bigger dog, quite a big, like 60 plus pounds, big dog. When it was on the table under anesthetic, so we had given it dexdomitor and butorphenol mixed together, and the effect of that dexdomitor brought its heart rate down to 48. So it literally goes from 120 within 20 minutes down to 48. That can be very scary for a lot of veterinarians, and that can be really scary for a lot of veterinary technicians as well, but it's normal. Remember that it's normal. So things that you would check, you would definitely check the blood pressure, see where their blood pressure is at. Are they okay? Are they pink mucous membranes? Are they breathing well? Does their heart have an arrhythmia? You'd go through the checks, but the bradycardia is totally normal. I've heard experts say that 30 is their cutoff. And if a heart rate for a dog goes below 30, that's when they start consider reducing some of these effects, which I'll talk about in a minute. One thing to remember, do not use, it's advised against to use, do not use anticholinergics with alpha-2 agonists. Anticholinergics, their goal is to increase heart rate. Anticholinergics have an intrinsic bradycardic effect. So if you give a drug that causes bradycardia and you give a drug that causes an increase in heart rate, you're going to fatigue the heart, and you can actually cause some damage to that heart muscle and potential cardiac issues. Uterine contractions can occur with high doses of xylazine in cattle, so be very cautious on the patient that you're using these on. You would not want to use it on a pregnant cow. And cattle need just 10% of the dosage of xylazine compared to horses. So that's a good thing. Much, much, much less. So do not use your horse doses on cows. And like I said, it causes vomiting, but that's a good thing if we're using it as an emetic agent. So the good news, we talked about the downside. We saw the fiery pits of hell when we're talking about the bradycardia and the potential for uterine contractions, etc., etc. Good news with all of this, it's completely reversible. And that's why we love this drug. A lot of us love this drug. So we have these drugs, yohimbine, edipamazole, and tolazine, and these are all the reversal agents that we use for alpha-2 agonists. So it's very exciting news. So if an animal is on the anesthetic or the surgery table, they're in the middle of surgery or even, surgery hasn't started and their heart rate is sitting at 26. So it's a big dog, their heart rate's gone down to 26. Everything else is stable, but you and the veterinarian are not comfortable with that heart rate at 26. Well, you can start giving tiny doses of a reversal agent just to take some of that bradycardic effect away from the patient. However, have to be very, very cautious that when you start reversing these drugs, these alpha-2 agonists, you are also reversing its analgesic effects. So again, we don't rely on this as a sole source of analgesic effect, and we would reverse it if we're using a reversal agent. And also, keeping in mind, if you give a reversal, they wake up very, very, very fast. Like within 10 minutes, they might start waking up. It's pretty wild. And how it works, you give the alpha-2 agonist is an IM injection. Some of them you can give IV, but most often we're giving it intramuscularly. And essentially with the reversal, the dose of the reversal at least for dexdomitor, which is our most commonly used in small animal practice, the amount of reversal, the volume, is the same as the amount of dexdomitor that was used. And you give it as an intramuscular injection, and the animal wakes up quite quickly. So be prepared. So looking at the reversal agents, here's how they pair. We have dexmedetomidine, which is also known as dexdomitor, and its reversal agent is edipamazole, also known as the trade name antecedent. We have ditomidine, Sorry, that's spelled incorrectly. It should be ditomidine, and its trade name is dormicidin, and its reversal agent is telazoline. And then we have xylazine, also known as rompin, and yohimbine is its reversal. And now we have our handy dandy little chart. So xylazine, ditomidine, medetomidine, dexmedetomidine, and then romifidine. So romifidine is a lesser used large animal drug. It's not, I guess it's not that lesser used, but we do tend to use, I find we see dormicidin more often than Sedivet. So these are alpha-2 agonists. They're a sedative with some analgesic properties. They are not controlled drugs. Mode of action, alpha-2 agonist decreases norepinephrine secretion, so that in result causes sedation. Positive effects, profound sedation, some muscle relaxation, analgesia, happy blood pressure, and they're reversible. So they typically maintain good blood pressure and they're reversible. It's an emetic choice for cats and it's great for visceral pain in horses. Side effects, there's initial vasoconstriction, marked bradycardia, not safe for animals with cardiac or respiratory challenges, caution on its own for fractious or stressed animals, uterine contractions in cows, excess gas production in those barrel-chested dogs or cows, and then it does have a sealing effect as well. Again, young healthy animals is what we use these drugs on. Let us breathe. The lesson is complete. So that was a big one, a big lesson. We will take time to go through these again, especially as part of review, but do take some time to simply breathe and go back and have a peek at all of the drugs that we talked about today.